In addition to immune therapy, there are certainly some emerging targets that are very important in colon cancer. We recently heard about Beacon, and the Beacon study essentially was looking at a group of patients with BRAF V600E mutated patients. That's about 5%. In some reports, up to 8%, but I think it's closer to 5 to 8% of patients. Typically happens on the left side. So you have a RAS wild type tumor with a BRAF V600E mutated or mutation. Those tumors tend to behave incredibly badly, and they do not respond well to chemotherapy. Those are the patients where we think FOLFOXIRI perhaps plays a role in the first line plus bevacizumab, mind you, based on a subset analysis from another study. That's all the data we had, but we know those patients survive an average of 10 to 12 months, which is 1/3 of what you would expect for the average colorectal cancer patient. So really bad actors. And so we've tried for many years to toy around with the idea, well, how can we target RAF? It was done in melanoma very successfully. Even with single agent vemurafenib, you have 80 to 90% response rate. The first studies with single agent vemurafenib or others did not have much activity, 5% or less, and they did not hold for more than a couple of months for most of these responses. So it was frustrating, but it appears that the biology of colon cancer is a little bit different, that EGFR may become more relevant, and then hitting both RAF and MEK may actually make sense, and we know that from melanoma. But the EGFR angle is through a loop mechanism that makes EGFR relevant again. So a triple blockage for blocking MEK, blocking RAF, and blocking EGFR would make sense without chemotherapy. So encorafenib, binimetinib, and cetuximab was taken into this Beacon trial versus FOLFIRI plus cetuximab versus the doublet. But primarily what was reported out right now is that the study was positive. That's a phase 3 study, which essentially the triple agent had a 26% response rate versus 1.4% for the FOLFIRI cetuximab. A huge difference. And the survival was more than 3 months on average between the two. So that establishes a new standard for us. It's already making its way, if it's not now on the guidelines. We had another study from SWOG that was included in the guidelines based on a phase 2 randomized. That's a phase 3 study, so that's level 1 data, solid data, and that's going to transform the landscape of how we treat BRAF mutated patients, V600E. And in all frankness, I think this is underway. We should start thinking about taking this to the first line because of the bad biology of this disease. The other target of interest that's emerging is HER2. So HER2 amplified tumors are relatively behave better than the BRAF mutated, but they don't respond to EGFR inhibitors, even in the setting of RAS wild type. So there are multiple strategies that are being developed. One of them is a study with an agent called tucatinib, which is an oral agent that is very specific for HER2, and trastuzumab. And we have some data that will be presented at ESMO. We know some promising data from lapatinib plus trastuzumab. We also know of some promising data from pertuzumab plus trastuzumab in colon cancer as well. So that will become one day, I think, one of the ways we're going to transform the treatment of HER2 mutated. And then the last target of interest that's very clinically relevant, although it's almost like throwing a fish line into a big ocean, hoping to catch a big fish, that's the NTRK fusion. It's only in about 0.3 to 0.7% of colon cancers, but if you find it, the response to larotrectinib is significant. These patients respond incredibly well, and some of these responses can be quite prolonged. Now, the unfortunate thing is that there are very few of those, so it gets frustrating and sometimes you may miss them even on a report. They're being reported more consistently with some reports. So I think as long as we continue to consistently genotype all these tumors, we will be able to capture most of these alterations early on and be able to plan for the patients to be included either in trials, standard of care, or exclude some agents like EGFR inhibitors, or even think about immune therapy or an NTRK inhibitor like larotrectinib.
I will not say there is a single novel agent that is promising. What I will say is promising that if we get more information, especially with these new molecular diagnostic tools such as next generation sequencing approach, before we start treatment of metastatic disease, we will have a more clear picture of what is the disease and how are the clinical characteristics of the patient we have to treat. And then we can use our therapeutic weapons at the best, in the best combination, the best sequence. And I think this is the most important thing. And so molecular genotyping and molecular characterization will help really to personalize the treatment according to precision medicine in oncology.
From all we've seen in recent years, I think this is a very exciting time to be involved in clinical research and clinical development of agents and treatment options in colorectal cancer. We've seen new agents come about, new treatment options. We decipher biology, the interaction with the immune system. So we've definitely made improvements. And improvements right now mainly benefiting certain subgroups of patients. We talked about MSI high tumors, BRAF V600E mutant tumors, HER2 positive tumors. And hopefully this approach of profiling, using biology to guide our treatment, will eventually help even more patients. And the holy grail, of course, would be to make immunotherapy work for a larger numbers of patients, find markers for patients that could respond to immunotherapy, perhaps augmented immunotherapy with a little twist, kicking the immune system into gear, making immune cells more immunogenic, tumor cells more immunogenic. That, I think, is the future. And I've honestly never been more excited about where we are right now, where we'll go, than at this point in time.